Okay, well, let's get started. Welcome everybody to Grand Rounds. And in the age of COVID, continuing to make use of virtual technology, which has been good in terms of making attendance easier and also helping to boost attendance because more people attend this way than we have seats in the auditorium for. So when we do get back to normal, I think we'll have sort of a hybrid mechanism. But reminds me when the Katie study was reporting its results out after much anticipation and so forth. There was a press conference organized, and so was myself and the NIMH director, Tom Insel, and the dean of the medical school. And we go into the room and there's all these cameras and there's like 6 people. And, I said, where's everybody? He says, idiot, you're not talking to the people in the room, you're talking to the people out there through the cameras. So Gaurav, you're talking to the people out there. Next week, there's not going to be any Grand Rounds, but the week after we have our Viola Bernard Grand Rounds, and that'll be presented by Dr. Sherry Toth, who's a professor of psychology and psychiatry at the University of Rochester. Just an announcement before we get started. The APA SAMHSA Minority Fellowship Awards have been announced, and 2 of our residents, both PGY2s, have been recipients. QO, who's a PGY2, was one recipient, and will be working with Sydney Hankerson and Myrna Weissman to facilitate Korean Americans who are pursuing careers in medicine or mental health professions to become interested in psychiatry. And that seems like it's very timely given what we're seeing with regard to the ethnic and racial biases against Asian Americans or against Asians. Also, Jade Avery, PGY2, will be working and expanding the scope of what's been an enormously successful fellowship program, the June Jackson Christmas Summer Fellowship Program, which was really founded by Patrice Malone and now under the auspices of Patrice, Jane Marie Bradford, and Melissa Arbuckle, which offers minority and particularly African-American med students the opportunity to come to Columbia for the summer and have a psychiatric experience to give them a sense of what a career in that discipline would be. So it's great that Jade will be working to help expand that. Our speaker today is our own Gaurav Patel, homegrown mostly. He's a native of the Midwest, born in Chicago, went to undergraduate school and then medical school and graduate school in neuroscience at Washington University. He received an MD and PhD, and his thesis advisor was Mauricio Corbetta for work he was doing in the neurobiology of cognition in subhuman primates. Gaurav then came to Columbia and PI for his residency as a Levy Fellow, which accorded him an opportunity to continue pursuing research at some level while he was being clinically trained, and then proceeded to complete a postdoctoral research fellowship, and now is a faculty member of the department, and also is the co-director of a new program that we've sanctioned and committed support to that is really in evolution. I'll say more about that in a second. But Gaurav has done work at a very high level with a very sophisticated technological orientation, initially in anatomic and neurobiologic studies in subhuman primates. He was a co-author in those early days with a number of people, including people like David Van Essen, published in Nature, Neuron, PLOS. And then since emerging from his clinical training, has been focused on human subjects-oriented research using neuroimaging, but also with a very strong cognitive and computational sort of approach to that. And in this context has been successful in the way that academic prowess is measured by publishing, but also very significantly in terms of being competitive in receipt of NIH grants. So he was awarded all in the same, I don't know if it was funding cycle, but the same year, two R01s, one on behavioral neurocorrelates of deficits in naturalistic visual and auditory social cognition in individuals at high risk for schizophrenia, and then another for neural substrates of deficits in naturalistic social cognition in schizophrenia. So Gaurav nobody can accuse him of taking the easy low-hanging fruit as his scientific targets. I mentioned before that he with Guillermo Jorge are really leading a new initiative in what Blair and I and others have been referring to as big ideas. And Jonathan Posner was one of the sort of co-founders of one of the preceding big idea, the idea with Cristiano Duarte of establishing a center for intergenerational psychiatry. Guillermo and Gaurav are forging a path in terms of bringing computational approaches to the study of mental disorder, brain function using various technologies and computational approaches. And this is sort of still inchoate, but is committed to and will take form in terms of space and formal organization and funding very soon. The name of it goes by C3N, which stands for Cognitive, Computational, and Clinical Neuroscience. And they'll explain more exactly what that entails, or Gaurav will in the course of his talk. But in any event, it's good to have him here and be able to provide us with an update of what he's been up to these past number of years and where things are heading in the context of his work in his laboratory, as well as the C3N Center. So Gaurav will be talking about neural substrates of social dysfunction and schizophrenia. Take it away.
All right. Thank you, Jeff, for that generous introduction and for having me, inviting me to give grand rounds, something I've been looking forward to for some years, seeing everyone else come up on the stage and give amazing presentations here. So I hope I can live up to the standards. Let me share my slides. And all right, so if I've done this right, you're now seeing a title slide here.
Sorry, Gaurav, sorry to interrupt. You're actually in presentation mode. So we can see your notes in the subsequent slide also.
Oh, that's weird. All right, let's stop that.
You can just swap your displays.
Yeah, I think this is just a weird keynote thing. So move this over here. All right, so now if I hit play.
Good, you're all set.
All right, sorry about that. So, all right, so as Jeff said, I'm going to be talking about some of the research I've been doing, started as a fellow and onto K Award, and then now moving into these two R01 funded projects on neural substrates of social dysfunction, schizophrenia. For some disclosure, my wife works for Pfizer, though they've left the CNS space, so it's nothing, certainly nothing related to anything I'm going to do here. So schizophrenia. So when most people think of schizophrenia, people think about the positive symptoms, the hallucinations, delusions, et cetera, paranoia. You know, these are, after all, the symptoms that that land individuals into our CPEP and psych-ERs in general. And ones that we actually, you know, have reasonable treatments for. Those certainly they could stand to be improved. You can see here in the DSM-5 criteria for schizophrenia that these positive symptoms are relatively well enumerated and of course are required for the diagnosis of schizophrenia. However, the other side of things, the negative symptoms, the cognitive symptoms, those are relatively poorly defined in our criteria and don't play as much a role in the diagnosis of schizophrenia. In the research world, there is a little bit more attention paid to these symptoms in that, they're often subdivided into domains of negative and cognitive symptoms with constructs, subconstructs within those. But even then, those constructs are still relatively poorly defined and not easily measured. Moreover, the mappings of many of these constructs onto the brain are relatively hard to imagine. So for instance, social withdrawal. How do you measure social withdrawal, and certainly how do you find the neural substrates of social withdrawal? So, and this is an important. These are important symptoms to try and understand. Of course, about 1% of the population in the U.S. and worldwide can be diagnosed as having schizophrenia. In this population, there's many things that cause these individuals to have problems. One of them is that they have a relatively hard time participating in society, and this is reflected in a number of things, such as the unemployment rate in this population being around 90%. And, as I said before, while we have treatments for the positive symptoms, treatments for these negative and cognitive symptoms are relatively hard to come by, if there are any at all. These social functioning deficits that prevent people from participating in society, they're established early in the diagnosis, which of course occurs early in adulthood. And they remain stable for at least 20 years without any effective treatment. So where you're at within 6 months in the longest running study I've seen, where you're at within 6 months of your diagnosis in terms of your ability to function in society is where you're going to remain for the next 20 years for the most part, and independent of treatment or anything else. And moreover, the ability to function in society in this population has relatively isn't terribly well predicted by the level of positive symptoms, as you can see in this one study, finding a relatively low correlation of positive symptoms and interpersonal behavior. What does, of course, predict your ability to function in society is, a mix of the cognitive and the negative symptoms. But as I said before, these are largely not treatable, and whatever treatments there may be, such as some of the ones that Alice Medaglia has pioneered, are still largely inaccessible to many people. And of course, the antipsychotic medications that we use to treat the positive symptoms don't affect these social functioning symptoms at all. One of the reasons, of course, we don't have treatments for these social functioning symptoms and the underlying social cognitive deficits is that the neural and psychological mechanisms are relatively poorly understood. And why is that? As I've already alluded to before, it's complex. There's a lot of things going on. There's a lot of subconstructs underlying these kind of broad umbrella terms like social functioning, social cognition, et cetera. And involves many kind of underlying sensory and cognitive systems working in concert. And it's also hard to quantify. As I was saying earlier, how do you quantify something like social withdrawal? How do you quantify that and be able to use it to try and then look at correlates in the brain? So I realized this as a medical student after completing my PhD work at WashU and coming back and doing my psychiatry rotation and seeing that there were that a lot of psychiatry in my mind just instantly became obvious. It was applied cognitive neuroscience, and I saw a lot of correlates to the work that I had done as graduate students in potential correlates to the clinical world. My background, as Jeff said, is in visual attention and understanding the neural function, the neural correlates of visual attention. And, you know, one of the key things in social functioning, social cognition, of course, is what, well, if we were in the type of Zoom session where you had a lot of people up on the screen right now, or if we were live, it's what we'd all be doing, which is scanning the various faces in our in this kind of complex dynamic social scene that we'd find ourselves in, and looking for social cues, such as changes in facial expressions, eye gaze, etc. This is something that you know, so we do a couple times a second on average, and is critical for our ability to understand what's going on in a social situation. It's critical for us to do this well and do it efficiently. Um, in the world of visual attention, we have a pretty good understanding of the systems that are involved in these quick automated decisions of where to look in these complex scenes. Um, which was originally described by my thesis mentor, Maurizio Corbetta and Gordon Schulman in a 2002 paper, and updated by us in a review in 2008. This theory, or this model of visual attention, describes how a number of cortical areas are involved, interact with each other, and cortical systems interact with each other to take in visual information, process it to understand what is salient, what is potentially behaviorally relevant in this complex, moving, dynamic visual scene, and then control the direction or the guidance of attention or eye movements. And when I say attention, I mean covert shifts of attention. So, you know, as you keep your eyes focused, you may, you know, in the corner of your eye, you know, attend to something kind of in your peripheral vision, or overt shifts of attention where you actually make an eye movement to that salient stimulus in the visual scene. Um, all of that is controlled by these systems that have been described over many years by any number of investigators, including people like Mickey Goldberg, Vince Ferreira, and Jackie Gottlieb here. Mickey in particular has done a lot of the seminal work in understanding how these systems interact to control the guidance of eye movements and attention. Now, one of the things that Maurizio and Gordon realized early on is that while there are these dorsal attention systems, as they described them outlined here in blue, that were relatively homologous in a number of ways to the systems that have already been described by Mickey and others in macaques, there was this whole other system that they found active in the human brain called the ventral attention network. The key node of this ventral attention network is the right temporoparietal junction. This was the area that Maurizio early on found to be the basis of visual spatial neglect. Strokes in and around this area, especially to the white matter underlying this area, result in that the visual spatial neglect, the idea that you're unable to orient to the left visual field, and are hyper sticky in orienting your attention to the right visual field. So, you know, we created this box and arrow diagram of how areas interacted to within the visual attention network to what role it may be playing in the control of visual attention. But many of these arrows were, you know, purely hypothesized because we didn't know what a macaque homologue of these areas were. So we didn't have detailed anatomy to tell us how the TPJ, for instance, may be connected to other areas. So this became my job in graduate school, was to go and find this area in macaques. And long story short, what we found is that it didn't exist. This entire ventral attention network did not seem to exist in macaques. Moreover, as we looked at this, and this is summarized in a review that I wrote with Maurizio a couple years ago, the part of the brain, the temporoparietal junction where this key node sits, has been massively expanded in humans compared to macaques, as shown here in the kind of the expansion of the red outline here. and shown here by work by Jason Hill, when he showed when you stretch a macaque cortex to fit a human cortex, the temporoparietal junction, in addition to the prefrontal cortex, is one of the areas that you have to stretch the most to fit a macaque to human, implying that this is an area that's massively expanded in the parallel evolution between macaques and humans. So not only is it one of the areas that's most massively expanded in humans, it's also one of the areas that develops latest in humans, and this also came from Jason Hill's studies, but has been confirmed in various ways by Ted Satterthwaite and others who've looked at the development of this part of the brain, showing that this is an area that develops fully matures around late adulthood, which was interesting from the point of view of schizophrenia, because this is one of the areas, schizophrenia, of course, the onset is often in early adulthood. So, what I began to think about was that this complex, massively expanded in humans, first of all, we couldn't study it in macaques because it didn't really exist in macaques. So we had to find ways of studying it in humans. And one of the first things was trying to understand what were the components of this complex and how might they be relevant for these kinds of everyday behaviors that we are involved in, reorienting attention a couple times per second, in the navigation of a complex social scene and other things. So I've already described to you, the ventral and dorsal attention network in some detail, which are involved in the orienting and reorienting of attention. And again, this is happening a couple times a second. This, of course, is working in conjunction with visual processing areas that are taking in visual information, especially in terms of a social scene. So in particular, there's a set of areas that are involved in the processing of motion, and another set of areas in ventral occipital cortex are involved in the processing of faces. And these seem to converge in the posterior STS, and a set of areas often called the STS face areas, that are involved in the processing of moving facial expressions. There's another set of areas involved in social cognition that are often referred to as the theory of mind network, that includes a key node in the temporoparietal junction and the posterior temporoparietal junction on the angular gyrus, that are involved in the modeling of what others in a social scene may be feeling or thinking, or and then making predictions about what they're going to do in a social scene. This is a network that's been described by Rebecca Sachs at MIT and others. And the temporoparietal junction node is a critical node in this. And this is also a network that heavily overlaps with the default mode network, for those of you that are familiar with that concept. Of course, these areas are working in concert, are working all the time. They're not, working one at a time. They're working all together. And of course, there are key nodes of all of these networks in the temporoparietal junction. So seeing this, what I thought was that that this must be a critical kind of a hub for social cognition operations, for these social cognition behaviors of taking in visual information, understanding what's, making some sense out of it in terms of what's going on in the social scene, and then guiding behaviors based on that information. And so now, to really understand how these areas may be interacting and how this may go wrong in a disorder like schizophrenia, what we need to do is be able to understand the functioning of these areas at many different levels. So, what we want to do is understand these areas at the level of what their structure is, how they function, how they coalesce into networks, and how those networks interact. and how those interactions lead to behavior and the symptoms that we see that impair social functioning in this population and others. And to just give a sense for those of you that are RDoC aficionados, these are kind of the rough approximations of those RDoC levels of analysis to this scheme of understanding the levels of interaction in my model. And moreover, we don't want to just understand these levels of interaction just in one area, right? We need to really understand how all of these areas are working together. We need to be able to understand how these areas are working at all these levels across the entire brain simultaneously. And so for this, we turn to what we did was turn to movie watching stimuli. So these movie watching stimuli, when an individual watches a movie, those stimuli emulate a lot of the dynamics and the complexity of what goes on in real life when you're engaged in a social situation, including the kind of complex moving stimuli that are on screen, eye movements that you have to make to kind of keep track of what's going on, and the types of quick dynamic cognitive operations that need to occur for you to keep up with what's going on in the social scene. And a bonus to using these stimuli is that, unlike a lot of complex cognitive paradigms, they're relatively easy to administer, which is important when you're working with a patient population that has any number of cognitive deficits and other issues going on. So our approach to understanding these social cognition systems and where their deficits may lie within those systems is to look at, to use these movie watching stimuli and eye tracking to look at things across all of these levels. So that's what I'm going to describe for you today, is the work we've done to first look at the how eye tracking patterns may differ, or visual scanning patterns may differ while individuals watch movies of social situations in individuals with schizophrenia versus healthy controls. Then look at some of the functional deficits that may underlie those differences in visual scanning, and then ultimately how structure and function may lead to those functional deficits. The structure-functional relationships may lead to those functional deficits. And in the end, I'm going to describe a framework for how all of these come together, and so how you can go from an understanding of structural deficits all the way out to social functioning deficits. Now, keep in mind, this is a framework that has some gaps in it that need to be filled with some future investigations, but at least it describes things at all these levels and gives you a sense of how they may tie together. So I'll start by describing the study that we recently published on visual scanning deficits of social scenes. So to do this, we rely on a neuropsych test created by an Australian group some years ago to study social functioning in traumatic brain injuries, called the TACIT. TACIT stands for the Awareness of Social Inference Test. And it involves individuals watching short video clips of a social situation and then answering questions about what the main actor is thinking, feeling, doing, and seeing. And the main actors are instructed to either lie, a very flat affect lie, or, as you're going to see in this clip, be sarcastic in a very 7th grade kind of overly kind of affective sarcasm. So I'm going to ask you to watch this clip and then answer some questions afterwards, though I guess I'll just let you answer to yourself, since I won't be able to hear your responses.
I'm collecting for Peter's farewell. Someone suggested $20. Is that too much?
$20? Sure, I can afford that.
Does it leave you enough money for lunch?
Sure, I've got enough left for a 3-course meal with wine. Thanks for worrying about me.
So after watching this clip, individuals that answer these questions. Is Michael trying to make Olivia feel okay about asking for $20? Is he trying to say he's got plenty of money for lunch? Does he believe he's got enough money for lunch? And is he openly annoyed? And the individuals who take this test, their instructions are very simple. Just watch the clips, answer the questions. That's it. So when we look at performance, we replicate what other people have seen, which is that when the main actor is instructed to lie, individuals with schizophrenia are almost as good as people, healthy controls, in answering those questions. A little bit of a deficit there. But there's a much more pronounced deficit when the main actor is instructed to be sarcastic. And what this tells us is that the performance deficits are specific to the affect-laden sarcasm. Something about the sarcasm is what's driving these deficits. And it's not something as general as like the individuals with schizophrenia just didn't understand the instructions or weren't awake or weren't able to pay attention. They were, as you can see from the lie condition. And other people have shown that performance on this task correlates with social functioning measures. So, of course, as I said before, what we did while individuals were performing this test was to keep track of their eye movements. And this is kind of what it would look like. So each dot here is an individual's eye position on every video frame. The cyan dots are the healthy controls. The red dots are the schizophrenia patients. And the ellipses just kind of represent the distribution of each population. And what you see is that individuals, the healthy controls are often fairly stereotyped in that the ellipse is smaller, like in this freeze frame here, and that they're all spontaneously deciding who to look at in the scene or what to look at in the scene. Simultaneously, the individuals with schizophrenia are often not looking where the healthy controls are, and they're on average much more divergent at certain moments, but not all moments. And we can see that in this graph, which plots the average for each population of how divergent they are. And I can get into the details of the measure of divergence if anyone's interested. Is that the healthy controls are relatively stably convergent on what they're going to be looking at, and there are these moments, such as in this freeze frame, but other moments as well, where they're highly divergent, right? So then the question is, and also the degree of divergence of any individual in healthy controls predicts how well they do on performing on answering the questions on tacit, but doesn't in schizophrenia patients. The only thing that does predict tacit performance in schizophrenia patients is processing speed, which is a neuropsych measure of how quickly you can kind of, in a very top-down way, search a visual scene. And we'll get back to that in a second. So, of course, in the question,
Gaurav,
yep.
You may be going to answer this, but let me quickly ask, do you know whether it's just inattention or they're focusing on the less salient things?
Well, yes, I am about to answer that in some detail, though there remains some work to be done. So let's take a look at how we actually did try and answer that. So what we did was, first, we modeled each individual's visual field using something based on the way cortex is organized, the V4 cortical magnification factor. Essentially what this does is, as you can see here in this rainbow circle, is that it weights stimuli that are at the fovea over stimuli that are in the periphery of the visual field. And then using Amazon and some other visual computer vision algorithms, Amazon's recognition service, we automatically classified where faces were in the scene on every video frame. Now, between the visual field and where the faces were, we calculated an overlap score to see, to what degree does any individual's eye position overlap with the faces that are in the visual scene. And then we divided it up by in the previous figure, those moments where they're highly divergent versus not divergent, where the individual schizophrenia are highly divergent versus not divergent. And what we see is that the overlap of the visual field and the faces for healthy controls, whenever individuals with schizophrenia are highly divergent, individuals with the healthy controls are often looking at faces, as you can see by this blue bar being higher in the divergence periods versus the non-divergence periods. Excuse me. And individuals with schizophrenia are often missing those faces. They're not looking at faces in those moments. So in this automated way, we are able to assess that that individuals with schizophrenia, the schizophrenia participants, miss looking at faces. But then the question is, as Jeff was asking,
why do? Oh, interesting. For some reason, my AirPods have disconnected. So I think I will be using this. Can you guys still hear me okay?
Yeah, we can hear you.
Okay. Why do individuals with schizophrenia miss looking at the faces? So what we did was also then run some low-level feature detection algorithms, as seen here for motion, and quantified frame by frame, and in these 1 degree by 1 degree boxes, what the content of the visual fields were. And we then combined them with our face recognition algorithm here to see, and then looked at all of the saccades 2 faces and quantified what was going on in the face before they looked at it. To see, are there any differences in the visual features of that face before they look at it, with the idea that, that might predict why individuals are looking at those faces. And this is what this kind of plot looks like here, where we have now divided out all the saccades to faces by saccade amplitude on the x-axis and the speed of the motion in the face on the y-axis here. And what you see is that there are a lot of small amplitude saccades to motion within the faces at any number of velocities here. And then there's a distribution where there's some saccades, into peripheral vision, 5 degrees and greater, to what I would call low motion in faces. And now we compare this pattern to the individuals with schizophrenia, and what we see is something broadly similar, but there is a deficit or a relatively lower number of saccades made to slow moving faces in peripheral vision. So this tells us that for some reason, they are missing looking at faces in the periphery. And what this basically means is that, and there's no similar deficit for contrast, luminance, or motion to non-face objects, or motion within non-face objects. So what this basically means is that individuals with schizophrenia fail to detect moving facial expressions in peripheral vision, right? So that's pretty specific. It's motion in the periphery that they're failing to detect. And what this basically translates to is essentially that by failing to detect these moving facial expressions in peripheral vision, they don't orient to them. So they don't make eye movements to them to bring those faces into their foveal vision. And they're then miss critical information that is useful for understanding what's going on in the social scene. So the next question then we asked is, what are the neural underpinnings of these deficits, right? So where in all of the brain areas that are involved in processing these complex stimuli may there be deficits, and what might this tell us about, what's going on to cause this visual scanning pattern difference in schizophrenia patients or participants? So, again, here's the kind of the complex schematic of all the various areas that may be involved in processing these complex social scenes. And here's what it looks like in reality. So underlying here is the statistical map of, in healthy controls, all the areas that are activated when you're watching these social scenes in the scanner while we collect fMRI data. averaged across about 12 participants. And then the colored outlines here are what we call regions of interest, ROIs, that are have been defined not by any of the resting state parcellation schemes that are available, with the exception of the auditory areas in brown, but by functional localizers. So these are localizers that are designed to maximally evoke activity in certain systems. So in yellow, for instance, we have the systems that are activated by a localizer, a theory of mind localizer, or mentalization localizer that Rebecca Sachs designed, in which these are the areas that are active when individuals are watching a short Pixar animated movie that has certain moments where there are what are called tertiary theory of mind events occurring. These are the areas that are activated during those moments. In blue, we have areas that are activated, and the dark blue areas that are activated when you're processing moving facial expressions based on a localizer designed by Antigona Martinez and Dan Javitt. And the other colors outline areas that are activated by an attention localizer that allows you to localize and subdivide areas that are involved in processing visual stimuli, attending to visual stimuli, and then the general kind of task control of keeping you on task. Now, what we want to do, of course, then is to see where there may be deficits in the processing of these complex scenes, these movie-based stimuli. For that, to do this optimally, we had to use longer clips than what are available in the tacit. And we chose to replicate an experiment done by Uri Hassan back in 2004. We had individuals watch a 15-minute clip of the movie The Good and the Bad, the Ugly in the scanner. And using something called intersubject correlation to then pull out the activation patterns. And this is what the activation patterns look like for healthy controls watching the movie in the scanner. Critically here, and you can see by the lack of activation in auditory cortex, we cut out the auditory track. So people were forced to use eye tracking, visual scanning of the scene to keep track of what's going on. And this is what it looks like for healthy controls watching the movie clip. This is what it looks like for individuals with schizophrenia. The patterns are largely the same, but when you contrast them, which is good, that means that they're, the individuals with schizophrenia are awake and are doing kind of, to first approximation, similar kinds of operations as the healthy controls. When you contrast them, though, the biggest deficit is in the temporoparietal junction. Right smack dab in the middle of the temporoparietal junction, between these areas that are outlined in yellow right here. Can you guys see my mouse?
We can see it, but it's pretty faint.
Okay, so there's this yellow area here on the back of the temporoparietal junction that is, as I said, involved in theory of mind operations. This green area, that is the ventral attention TPJ that's involved in reorienting of attention. And then these blue areas here that are involved in processing of facial expressions. And in between, there's this red area that wasn't well localized by any of our localizers. So I just outlined it and called it the TPJM for middle of the TPJ. And it turns out that's exactly where the deficit is. And what's interesting about this area is that Jonathan Power, in a study he did in grad school in 2013, found that this is one of the areas that is likely some kind of cognitive system hub, defined as an area that is adjacent to a maximum number of other functional systems. So we started thinking of it as a hub. And then wanted to examine how the whole TPJ PSTS complex reacted, how the activity there was correlated to the processing and behaviors done while watching these complex movies. So the first thing we did was to calculate the frame-by-frame motion in the movie and then correlate that with the brain activity. And this is what you get again in healthy controls. You get robust correlations of brain activity of individuals watching this movie and the motion in the movie in areas like MT, as you would expect, the primary motion processing, cortical motion processing center, but all through the visual cortex in the dorsal attention network, et cetera. And of course, robustly through the temporoparietal junction, through the posterior STS and this TPJ hub area. This is what it looks like in individuals with schizophrenia. Again, broadly the same pattern. You get the dorsal attention system visual areas, but of course, when you contrast them, the biggest deficit is, again, right in the middle of the TPJ, this TPJM area. So this seems to imply that the visual motion information is not making it to the TPJ. Now,
Gaurav, can I ask a question? Just to maybe only for myself, or maybe for other people listening as well. You're manipulating or you're assessing three variables here. You're looking at the the visual, what people are visually attending to, what their hemodynamic response is, and then their performance, their cognitive performance on the task.
There's no cognitive performance in these tasks. They're simply just asked to watch the movie. We do ask them after the movie to, to summarize or answer a few questions about the movie just to make sure they were paying attention. But there's no cognitive performance on this task. But I'll show you.
What about on the previous one?
There is on the tacit. And I'm going to show you some data linking these two in a second.
Okay, because the question I was going to ask is, I mean, this is elegant work, but how do you know that the phenomena, the hemodynamic and the visual attention is actually reflecting the cognitive function that you're ascribing to it?
So right now, so in the initial analysis where you just look at what's activated, there is no ascribing a function to it. We only can ascribe function by virtue of where in this functional localizer scheme that I've laid out, the deficits, the activations and the deficits are. But what we're getting into now is a little bit of that, though it doesn't fully kind of delineate all of the operations involved. So here, what we've done is just look at the visual features that are in the movie. So in this case, motion, and see what brain areas correlate with the motion in the movie. So here, what we can say is that something about motion processing has gone wrong in the TPJM. Now, what's interesting is the TPJM is not a motion processing area. It does not show up on any motion localizers. It is not an area that's ever been implicated in the processing of motion. So what that may suggest, so the combination of this observation with the previous knowledge suggests is that maybe this could be a primary deficit of the functioning of the TPJM, or it could be the TPJM deficit could be downstream of some other deficit that we're not seeing in these in this analysis. And I'll touch on that again in a second. So this is correlating visual features with what's coming into the brain with what's going on in the brain. As I said, once the visual information is in the brain, then of course various areas communicate with each other in the processing of the incoming information. And so this is what it looks like for for area MT. This is essentially an analysis that looks at the health of the synchronization of MT to all other cortical areas on a voxel-wise basis. And you see something that's pretty similar to the motion processing map, but shows that in healthy controls, MT is well synchronized to the dorsal attention network and of course the temporoparietal junction. This is what it looks like in patients. Again, similar, but some differences. And of course, the biggest difference is the temporoparietal junction. So now we're getting into how well brain areas communicate with each other. And we can see that that MT in this same map is present for the any dorsal attention or visual processing area, that the TPJ is just not communicating with the rest of the areas that are involved in the processing of these stimuli in individuals with schizophrenia versus healthy controls. Lastly, we can then look at saccades. So this is, all of the areas that correlate with the frequency of saccades made by individuals in the scanner. And you can see that again, as expected, the dorsal attention network, prefrontal areas are heavily correlated with that, as is the temporoparietal junction. This is what it looks like in patients. And of course, you know the story now. There's a big deficit in the temporoparietal junction. So altogether, what this says is essentially that there's something broken in the TPJ, or it's reflecting that something's broken, that it's downstream of. That prevents the right types of visual information from getting into this complex. It prevents this complex from communicating effectively with other areas, and it prevents this area from being involved in the decision to make saccades or to visually scan these complex visual scenes. And, to get at something that Jeff was asking earlier, why does this matter? What we can see is that the amount of activation, the scatter plot here, on the x-axis is essentially the amount of activation in this TPJM area, correlates with performance on the task that I showed you earlier on the sarcasm clips, only the sarcasm clips. It correlates quite strongly across both groups. So, we can see that it's functionally deficient during the visual scanning of naturalistic scenes, but we don't know exactly what this is. As I said, is this downstream of some motion processing failure, as Dan Javid and others have found in schizophrenia? Or is this some primary failure of the temporoparietal junction complex that may be, as we were talking about earlier, perhaps the result of the failure to develop this area appropriately through appropriate synapse elimination or other mechanisms. So to try and get at this in a little bit more depth, this study is now in press at Brain. There is a preprint or an advanced publications available, but the final version isn't quite available yet. Hopefully in June it will be. So the last study that I'm going to talk to you about in some detail here is something we're planning to submit within the next few weeks, and is going to use resting state functional connectivity and as a stand-in for neural structure, and to look at the relationship. How does it predict the functioning of these areas? So in resting state functional connectivity, to first approximation, the connectivity patterns that come out of that measure approximate the actual anatomical connectivity of areas. It is not 100%. I'm glad to talk in detail about that with anyone that's interested about what is and what isn't there. But to first approximation, it tells you something about not only how well areas are connected anatomically, but also how much they're used together. So in this kind of network graph that's laid out here, that's color coded by, again, these functional localizers that I ran, each of these areas, when they're together, that means that their connectivity patterns are pretty similar. The thickness of the line that connects any two nodes or areas here describes the strength of the connectivity as measured by the correlation coefficient at rest. And the size of the node here is what's called weighted node degree. So it's the number of connections multiplied by that area makes after you threshold at a certain threshold, multiplied by the weight of those connections. So, an area like, I think these two areas right here are area MT, left and right MT, and you can see that they have a lot of connections to a lot of other areas and are also very similarly connected to each other, or have similar connectivity patterns to each other. So this is what this, all those areas I talked about before, this is how they are connected at rest. This is what the connectivity pattern is here. And this is what it looks like in individuals with schizophrenia. Now, what's interesting about this is that, again, to first approximation, they look very similar, which is good. means that things aren't grossly different or confounded by some other factor that's affecting our measurements, like movements or something. And what you can see is this graph is subdivided pretty easily into these yellow areas. The theory of mind areas here now subdivided by where they are located in on the cortical surface. And this set of areas here, which are the visual processing, dorsal attention, and prefrontal singular percular areas. This set of areas here is often described as the task positive network, and this area as the task negative or the default mode network. So you can see, like many other people have seen, that there is some segregation there. What's interesting about the TPJ areas is that they seem to form like a separate connection between the visual processing areas and the theory of mind areas. And the biggest deficit we saw at rest was in the posterior STS and these blue areas in schizophrenia participants. So what this basically tells you is that there is a deficit that appears to affect one way in which visual information can get from visual processing areas, like motion information getting from the visual processing areas to the theory of mind areas. It affects one of those routes and maybe forces individuals with schizophrenia to rely on this other route through prefrontal cortex for that information to get there. Now, that's just eyeballing these data, but let's see if we can test this this hypothesis observation more rigorously. And here what I've done is now just collapsed all those nodes into their component systems to simplify the analysis. And what we can do is trace the shortest path that connects the early visual areas to right medial prefrontal cortex, which is one of these critical theory of mind areas that Rebecca Sachs and others have described. And in healthy controls, this is what it looks like. The shortest path goes through the posterior STS and then the temporoparietal junction, including this TPJM hub area, into the TPJP and then the medial prefrontal cortex. In individuals with schizophrenia, that PSTS deficit seems to shunt the shortest path then into, as I said, the task through the task positive network into the default mode area. So now it's going through prefrontal cortex. So I'll call this the prefrontal pathway and this the posterior STS pathway for shorthand. Now, so these PSTS deficits essentially seem to functionally lesion that pathway. Now we want to test, are there actually two pathways, or is this just some, trick of network graph theory? And does this actually force a dependence on prefrontal cortex? So to look at this, I looked at the connectivity of along the path and used it to predict the shortest path length of any number of areas, visual to medial prefrontal. In both groups, what you see is that the connectivity of visual to posterior STS areas predicts the overall path length from visual areas to medial prefrontal cortex along this PSTS area pathway. And moreover, this is true for the connectivity of any visual component to any theory of mind component. Now, what's interesting here is that the prefrontal, the shortest path length of the prefrontal cortex is not affected by the connectivity along this path, suggesting that there's some independence of these sets of areas from these sets of areas. Again, kind of saying that there are potentially two different pathways here. Then looking along this prefrontal pathway, what you might expect is that if this matters only for schizophrenia participants in terms of the structural integrity of the connectivity of visual areas to prefrontal areas, that you will see the correlation of connectivity strength along this pathway with the path length of visual areas to medial prefrontal theory of mind areas only in schizophrenia patients. And that is exactly what we see, is that the more strongly connected the dorsal attention and prefrontal areas are, the shorter the path length of visual to theory of mind areas are only in schizophrenia patients, but not healthy controls. And this result stands up no matter how you threshold the graph, and for other components of the prefrontal pathway as well. Okay, so that's fun, in terms of using connectivity strength of any two nodes to predict the overall structural integrity of these areas, but what about function? So going back to the movie watching data, we then asked, how does the connectivity along the two pathways, the PSTS pathways and the prefrontal pathways, predict the activation of the, again, this key theory of mind node, the TPJP, which is critical for the understanding, the functioning of which is critical for the understanding of others in these complex dynamic social scenes. And what we found is that in both groups, the connectivity strength of visual areas to the TPJM hub predicts the activation of the of this area while they're watching the movie. But along the prefrontal pathway, only in patients does the integrity of the prefrontal pathway predict the activation of the TPJP, suggesting that indeed that patients are uniquely relying on this prefrontal pathway to process the information as it goes through these sets of areas to then make a decision about what to do with these, what to do with that information and how to understand the social scene. Okay, so to summarize all together, I'm going to use this is the diagram I showed you, the schematic for how areas are interacting. I'm going to use a slightly updated version of this model that involves the TPJM and the prefrontal areas. And, classically, what people have generally talked about are the dorsal and ventral visual processing pathways that link the processing of, say, spatial information from the spatial visual information going through the dorsal attention areas to the prefrontal cortex, and then more object recognition processing going through this ventral visual pathway through the ventral occipital processing areas. As I've talked about, or as I've alluded to, we believe that the TPJ is a key part of a third visual pathway used by humans to optimally visually scan these complex social scenes. Remember, these aren't these areas don't exist or don't exist in the same way in macaques. And then what happens in schizophrenia is that there is some functional deficit or structural deficit within the TPJ-PSTS complex that basically impairs the use of this TPJ pathway, if not preventing the use of this TPJ pathway, to be able to optimally process these complex social scenes, and forces an over-reliance on these dorsal and ventral visual processing pathways, both of which rely on prefrontal cortex and are embedded in what I was talking about or describing as the prefrontal cortex pathway. And that this under-reliance on the TPJ and over-reliance on these other pathways then results in an alteration of the visual scanning patterns that you see in individuals with schizophrenia. Now, this might be described as a compensatory pathway, or it could be described as a secondary pathway that is now being used solely, as opposed to in conjunction with the TPJ, that if there are additional prefrontal deficits, and there's lots of reasons, of course, to believe that there are prefrontal deficits in some individuals with schizophrenia, that those prefrontal deficits represent a second hit that then really impairs your ability to, appropriately visually scan and understand these social scenes. So what are the future directions we're taking this work in? As Jeff discussed, we have two new R01 funded projects, which are in the past couple months have just gotten off the ground. And one of them is to examine these neural mechanisms and how they go wrong in schizophrenia in more depth. For this, we're going to use retinotopic mapping in a collaboration with Clay Curtis at NYU, who has a method that we've adapted to mapping the retinotopic organization of not just the visual areas, but also the dorsal attention areas and the prefrontal areas that are involved in the guiding of attention and eye movements. And the idea is that if our model is correct and the TPJ is interacting with these areas to drive visual attention, then we should see it at the neural level, that there should be correlations in the activity of the TPJ and the parts of the retinotopic map that are going to predict an upcoming eye movement. In addition, though, these data are going to be useful for any number of things in terms of just looking at the general dynamics of all of these systems involved and linking them to what's going on the screen. And so one of the things we've started doing recently is to now take these movie watching time courses and cluster them in time, and have found so far there seems to be 5 stable states that you see in these activation patterns shown down here when you cluster them in time, that the at least the healthy controls on average visit over and over again. We can then use the same cluster time points to look at what's going on in the individuals with schizophrenia. And what we see is that there are certain states in which there are deficits in activating the temporoparietal junction. And moreover, we can then predict when we know when in time those are occurring. So previously I was showing you that just where things were potentially going wrong. Now we can begin to start seeing when they go wrong. And of course, this is going to be critical for our understanding of how it relates to what's going on the screen and failure what things may be being missed by individuals with schizophrenia. We can also use these retinotopic mapping data to start looking at some of the things that have been predicted by computational models of microcircuits and how they are expressed in bolt signals. And this is an example from John Murray and Xiaojing Wang published in 2014, that we're going to directly be able to measure the width of these receptive fields and test John Murray's and others' hypotheses about how excitatory inhibitory balance may be altered in schizophrenia. Another R01 funded project we have is to look at changes in individuals who are at high risk for developing schizophrenia. So the idea here is to run these same movie watching, eye tracking, and imaging, get these markers in individuals at high risk when they come into the COPE clinic, run by Raghi and others here, and then image them again after they've either developed schizophrenia or just in general a couple years later to see what has changed in these systems. Do some of these deficits exist before the onset of schizophrenia, or do they develop through the onset of schizophrenia, et cetera? And we have some evidence to suggest, some preliminary evidence, that there may be differences in the presence of auditory deficits and visual deficits in the individuals at high risk for developing schizophrenia. That maybe there is a differential kind of time course of the development of these deficits through this period of time in young adulthood. Another future direction, first thing that everyone asks me whenever I present this work is, have you looked at this in individuals with autism? And that's what I'm hoping to get off the ground in the next couple of years, is to start looking dimensionally, not just individuals with autism, but also potentially individuals with anxiety disorders, because there's reasons to believe that anxiety as well disrupts the functioning of the schizophrenia, of the temporoparietal junction. And in individuals with autism who have, broadly speaking, some similar eye tracking, visual scanning deficits, and inability to use facial expressions to understand a social scene. Antigona Martinez and Dan Javitt have found that there may be some underlying neurophysiological differences despite these similar kind of phenotypes being expressed in both populations. Of course, I am a clinician, and so I'm interested in trying to understand how we can, develop new treatments around this. And one of the things I'm excited by is augmented reality. So there are now on the market, you can buy this today, a couple augmented reality systems, and there will be more available in the near future from, it sounds like, Apple and other manufacturers. This is a picture of the Microsoft HoloLens 2, an ungainly device, but again, you can buy it today, fits over your glasses. And what the augmented reality does is, it has a forward-facing camera, an eye tracker, and then also a graphics display system shown on the glasses lens. And you can use this, and people have already used this, to do things like face tracking. And so this is a live demonstration of some software that a group somewhere in Europe, I forget where now, wrote, where they can online, as an individual's walking around, identify faces. And the hope here is that if it really is, we can confirm these deficits have to do with the processing of moving facial expressions in peripheral vision. We can then highlight those faces for individuals with schizophrenia and train them to, or in real time, just have them orient to these faces that they would otherwise miss and potentially gain the information that they would have otherwise missed about the social scene. Getting back to the time course of these states, one of the things that we hope to do is to also then be able to disrupt or augment the activation of certain systems with TMS and other modalities at certain times when we know that they should be activated or shouldn't be activated in individuals with schizophrenia, or to causally test our models in individuals and healthy controls by disrupting the activity in the TPJ. Now, all of this that I've described has required us to set up a lot of infrastructure. And I'm a big believer in open collaborative science. So in addition to these projects, I've been working on a number of initiatives that would make these techniques more accessible to you, those of you out there at the Psych Institute, and for other researchers beyond. One of those is the MRI computing facility, and this in the past year has come into fruition in some usable way. And this basically takes those high precision neuroimaging pipelines that I've used and others have used in their research, and now have made them available to individuals to use through the MRI unit. And so this is a collaboration. I'm the MRI technical director, so this is a collaboration with Rachel Marsh, the MRI unit director, and Matt Riddle, who is the operations director, and then also Chris Stanley, who is the head of IT here at NISP of Psychiatry. We have built this computing cluster as a hybrid local cloud computing facility that now, when you acquire data sets using these high spatial resolution and temporal resolution sequences, on our MRI at NISP, you can run them through our standardized pipelines and get the results out relatively quickly. And it's included in the charges that the MRI unit charges for the hourly scan rates. So you don't have to worry about setting up, as I have, and you can see back here, this data center I had to set up some years ago to house all these data. You don't have to set up your own computing cluster. You don't have to set up your own data storage system. It's now all set up for you. And this will continue to expand in its abilities and scalability with time. The other thing, as Jeff mentioned at the beginning of the talk, is the C3N initiative. So this started actually now 5 years ago. This is as a speaker series co-directed by Guillermo Horga and I. We've now had, we haven't actually counted them up, dozens of speakers come through over the past 5 years. We've continued these in the virtual world over Zoom, just like the talk today. And we have a talk today by Sarah Yip from Yale, who will be talking about her work in terms of her computational work in understanding addiction and substance use disorders. and then our own Corinne Ford will be giving a talk in May. And she, in addition to talking about her work, will be kicking off soon with Ken Wegler from Guillermo's lab, a works in progress series that will be open to trainees at NISP and beyond who want to share their data and get feedback on things like trial designs and analysis and processing and that kind of thing. So please stay tuned for that announcement this spring. And then, as Jeff mentioned, Guillermo and I are working with the department to set up the C3N Center. And this is really going to be set up around not just advancing research in computational and cognitive neuroscience in clinical populations, but also in training other individuals, whether they're trainees or other PIs who are interested in learning to use these techniques for their own populations, and really set up to be a collaborative center, not just for amongst the various labs here, but also with the theory group at MBBI, with various data science initiatives with our own data science division here run by Melanie Wall and others. And of course, institutions outside of Columbia University and the New York State Psychiatric Institute, for this to be a center where this can all kind of come together. And if you have, questions or an interest in developing these paradigms, you'd be able to come to us. As a part of this, we are also hoping to find space and open up what we describe as a computational phenotyping core. Rather than us setting each individual lab setting up their own computer testing room and buying their own physio equipment and stuff, we are hoping to set this up as an open use facility that individuals can come in, especially people wanting to collect pilot data for future grants, have everything set up so they can set up their tasks on these computers, have access to cutting edge physio recording equipment through BioPack and other systems, and hopefully set up ways of causally manipulating the various models that will come out of the computational phenotyping core through TMS and other modalities.
Guillermo, Gaurav, let me just say, I could go on listening to you all day, but we do have a bunch of questions that are queued up.
Right. So with that, I will say thanks. And say thanks to the individuals in our lab. We couldn't do a lab photo because of COVID, but here you go. Ben, Alan, Nahian, Jessica, Ariella, Nicole, Juan, David, Safia, and Daniel, all of whom have contributed to the work that's presented and the ongoing work that started, including also these alumni. A special thanks to Dan Javit, who has been as generous as any mentor could be in terms of resources and with his time and support in helping me set up all of this and getting me to the place where I am at now as a principal investigator. Also Rachel Marsh for her support, Jack Grinband for his support over the years, and Guillermo for his collaboration and support in these various initiatives. And of course, the funding agencies, not least of which the Leon Levy Foundation for helping me get a start, and the NIMH for funding any number of initiatives along the way. And with that, I will say thanks and take any questions you may have.
Wonderful. Gaurav, that was really just a terrific presentation. Just a lovely example of how one can start with the foundational concepts from cognitive neuroscience and move them into clinical psychiatry. And I think that you're an example of, I'm sure, what NIH aspired to when they set up the MD, PhD programs to do exactly the type of work that you're doing. So thank you so much for presenting to us. There are a bunch of questions. I first wanted to give Dr. Lieberman a chance to ask a question, though.
Well, there's a lot of them in the queue, so I will desist and pick on Gaurav later, other than to say that the C3N Center is taking shape, with Guillermo Goro and also overseeing it is Blair. So if you have thoughts that you want to contribute to how this, to be considered how this evolves, Blair as well as Guillermo and Goro would be your points of contact.
Great. So Gaurav, one of the questions that came up was, you did a beautiful job describing the TPJ, its importance in schizophrenia and individual attention. But in the task that you provided, it was, the paradigm was around sarcasm, where the salience of it seems to be driven in large part by vocal prosody. It'd be good to get your thoughts on how relevant that is to your model.
Yeah, so I cut that slide out just for time. So the eye tracking measures contribute independently in healthy controls from understanding of auditory sarcasm, a measure that was developed by David Lightman and Dan Javits some years ago of understanding auditory expressions of sarcasm. So the eye tracking contributes independently of that in healthy controls, and both are deficient in schizophrenia participants. So we think that both are impacted differentially, and there's some evidence to suggest that there may be a capacity limit where some individuals with schizophrenia are better at visual scanning, some are better at auditory sarcasm. We can't be good at both.
Great. So Jeff Miller writes in, what a tour de force, congratulations on this work. Have you considered looking at borderline personality disorder? Might patients with BPD be hypersensitive to changes in visual expression in the periphery?
Yeah, one of the many disorders I'm interested in pursuing this work with. Jack Grunban has been working on a publication with others here using a what's called the cyberball task, which is a kind of a theory of mind task to look at the integrity of theory of mind systems. And we've talked over the years about adapting that to this framework. Many things to do. Haven't quite got to all of those things, but that's definitely on my mind.
Great. So the next question is from Rina Mukherjee, who writes in, do you find a graded neurological effect, or do schizophrenia patients always switch from one pathway immediately to the other in first episode schizophrenia? What are the chances of using these changes in network structure and function as episodic markers?
So these symptoms are relatively, as I said at the beginning of the talk, they're relatively stable across the lifespan. So the cognitive symptoms, the social function symptoms don't really change as of, with episodes of psychosis, as far as anyone can tell. But in terms of understanding, when the change in the reliance of the pathways occurs, that's exactly what the one R01 funded project is there to do. Is we will be performing these measures on healthy controls, individuals that are high risk for developing schizophrenia, and early psychosis individuals, people within a year or two of developing psychosis. So we can see, one of the ideas is to try and figure out as best as we can the timing of the onset of these deficits.
I would take a little issue with that, but I won't, ask you to. I want to ask you to elaborate on it. But just as a quick way of seeing the veracity of what you just said about these remaining stable over time, have you done any cross-sectional comparison between individuals who had been chronically ill versus the early stage subjects?
We don't have enough early stage subjects to do that. So that is, part of what that project was geared to do, was to get enough individuals, the upcoming project, to get enough individuals who are early in psychosis to do that comparison as well. One of the things we've done in the lab is, even though they're two separate projects, they're essentially the same techniques outside the retinotopy. So we'll be able to, simultaneously gather the cohorts of chronic schizophrenia, early psychosis, CHR, and healthy controls matched to all those different samples, so we can do that more rigorous analysis.
RNW, I'm not sure who that is, but writes in asking, as per Steve Kushner, could your data implicate a myelination problem between facial recognition and emotion?
Yes, so I spoke to Steve after his grand rounds, and that is definitely something we want to look at together with Guillermo. One of the things that comes out of these processing pipelines, which I was very excited about early on, was myelin maps, cortical myelin maps for every individual. Unfortunately, our previous scanner turns out had an artifact that affected all GE scanners using the Nova 32 channel coil that I helped discover, unfortunately, with Matt Glasser's help, that prevented us from using the myelin maps in those data. The good news is as far as I can tell, and I'm hoping to do a more rigorous study of this, the upgraded scanner with the new 48 channel coil does not have this problem anymore. And so that's one of the things I'll be looking at in this upcoming set of data.
Great. So William Tucker writes in, would it be fair to assume that blind people use voice scanning recruited from other brain areas to scan inputs and thus recognize social communications such as lying and sarcasm?
Yeah, and you know, there's a whole auditory side of this study that that I didn't really talk that much in detail about, and I am not an auditory neuroscientist, but that's we are collecting data from individuals just listening to a story now. We have some preliminary data that we're already looking at, as opposed to just watching a movie, so that we can get a better sense of what the integration is between the auditory and the visual side of things. There is lots of reason to believe that integration occurs somewhere in the TPJ-PSTS complex. And so we're hoping to look at that in more detail. But yeah, that's what I would expect, is that, you know, maybe there's a similar deficit in auditory processing somewhere in that complex.
Great. So I think that we're just about out of time, and that brings us to the end of the questions. So again, I wanted to thank you, Gaurav, and really congratulate you for such elegant and inspiring work. And I'll turn it over to Dr. Lieberman for a final word.
Brilliant. I mean, a real tour de force, Gaurav. Congratulations. And I will follow up with you to badger you about a few things later. Oh, last thing, just to be picky about this. Why did you pick a vignette with British accents?
Well, so this is actually, these are all the stimuli that are out there. All those social stimuli are relatively poorly done this way. So this one is the best that we could find, but you can see it's a low visual, low video quality, has the accents, all of that. So, and there aren't better ones out there. We tried to get a hold of a better one, but it turns out it was even worse in any number of ways. So one of the hopes is that moving forward, that we can design better stimuli, either movie watching stimuli, or my other real hope here is virtual reality, or video games or virtual reality. You can now, the game engines are sophisticated enough that they can create relatively realistic renderings of facial expressions and other things. So now we don't have to rely on, you know, movies with their whatever arbitrary decisions the person filmed them made. We can just create those stimuli on our own.
Okay, great. Thank you so much, Gaurav, and we will see everyone again in I think 2 or 3 weeks. All right.
All right. Thanks.